So welcome everybody to another OAO member spotlight. And today, this doesn't happen very often, but we do once in a while have a non-OAO member on the show. And in fact, today we have someone who is not even an optometrist. She's an occupational therapist. Her name's Julia Foster. Welcome, Julia.
Thanks, Jeff.
So I first met you back in April at the OAO annual symposium in Toronto because you had a booth at our InfoMart sort of describing the services that you offer. So maybe for the folks who don't know who you are or what you do, if you can maybe give us a brief introduction of the services that you provide.
So I'm an occupational therapist, and my role is I work at the Ontario College of Art and Design in a department called the Inclusive Design Research Centre. And although this is a research and design department, I am providing clinical services within this. So we have one of the regional assessment centers for the assistive devices program, and this is on the high-tech end of the assistive devices program. And so I'm seeing clients here and assessing them to determine what sort of high-tech devices are going to meet their needs from day to day with respect to reading, writing, and independence at home and in the community.
Okay, so as far as low vision services, some of my colleagues do provide low vision within their office, but typically kind of the low-tech vision aids, so handheld magnifier, stand magnifier, spectacle magnification. You know, what can you maybe talk about the differences between low-tech and high-tech?
Sure. So ADP funds both low-tech and high-tech devices, and the high-tech devices are assessed and authorized for funding through various centers across the province, including several at the CNI, different locations of the CNIB, W. Ross Macdonald School, the Center for Sight Enhancement, and a couple centers that only do CCTVs or large desktop magnifiers. On the high-tech end of things, ADP will fund a reading aid and a writing aid for clients who are eligible. And a reading aid would be something that helps you read back the things that you need to read from day to day. And this might either be a device that will magnify that information and provide visual enhancements, such as inverted contrast or high contrast color combinations, as well as other visual enhancements. It might be a device that will scan and read aloud the document. So you could place a piece of mail underneath and it would start reading back the information on that piece of paper. Or it might be something that has a bit of a combination of both, where it will read aloud the information but also display the text, which you can adapt to meet your visual needs. They also will fund a writing aid. So the program will provide funding for devices that will help them be able to record information as they would with a pen and a paper, but doing it with a device. So someone might be recording notes, writing letters and other communications, managing a calendar, etc. And often these are computer systems with software, or they might also be special Braille devices where somebody could record and read things in Braille. So those are the two different types of devices funded under the ADP program.
So for these high-tech low vision assessments, where do these patients, where do these clients typically come from? Or is it by referral? You know, how do these people find you?
It's actually a variety of different ways that clients will be referred to us. We do always need information from an eye doctor, either an optometrist or an ophthalmologist. But we do have individuals who will refer themselves. We get referrals from other healthcare professionals, occupational therapists, other doctors, etc. And at that point, we would need to touch base with the client to make sure that they have had a recent appointment with an optometrist or an ophthalmologist. A lot of our referrals do come from the low vision optometrists, and that's very important because it's often that our clients are using both low-tech and high-tech devices. So it is important that they do see a low vision optometrist unless there's definitely no additional devices that are going to help their needs on the low-tech side of things.
But back to the occupational therapist angle, obviously you can speak from that profession. Most of my colleagues would think low vision is delivered by optometry, ophthalmology, opticians, the Center for Sight Enhancement, which you referenced earlier at the School of Optometry in Waterloo. How does OT, how does occupational therapy fit into the mix?
There are only actually across Canada a relatively small group of occupational therapists who are working in the field of low vision. It's a lot more common in the States. Occupational therapists are quite involved in low vision rehabilitation. Occupational therapy, a lot of people have heard of it but don't necessarily know what it is. In this context, occupation is, the term isn't related to work, it's related to something that occupies somebody's time. It can be anything from personal care activities, getting ready in the morning, it could be something leisurely, knitting, sports, etc. Or again, tasks that you need to do for work or school or other demands that you have from day to day. And occupational therapists are essentially enabling the person to perform or be engaged in these activities. And OTs work in a variety of different contexts. They work with all ages, children, adults, older adults. They work in schools, workplaces, hospitals, rehab centers, the community, sometimes on their own, sometimes with other healthcare professionals. And what they're really looking at is they're looking at the individual themselves. They're looking at the things they do from day to day and how they do them, and what tools are available for them. And they're looking at their environments, not just the physical environment, but also the social environment, the cultural environment, the institutional environment, all of the different aspects that might be impacting how an individual is able to perform or has difficulty performing or is unable to perform a meaningful activity. And they will address different aspects. They're looking at the fit. So, for example, an individual who has low vision might have difficulty because all of the documents that they need to read are being provided in an inaccessible format. So they're looking at the fit between the person, what they do, and their environment, and addressing whatever factor is a barrier, or taking a look at the various factors that can be addressed to address that barrier. So is it teaching the individual new strategies, working with them to develop their own problem solving, so looking at metacognitive strategies so the individual is able to then apply that into other areas of their life. It might be addressing the environment, doing different modifications, looking at adaptive technology, lighting, etc., or changing how the activity or the task is done. So figuring out a different way to do it or different strategies that can be used to accomplish the same thing. So you could...
So in this case, vision could be one of those factors.
Exactly.
Limit them.
Mm-hmm. So in that example of doing something a different way, some clients might read a book with a special magnifier or specialty glasses. Someone else might read it with a video magnifier. Somebody else might listen to the book. Someone else might download it to their phone and listen or read it in large print. So there's various ways to, that's just a kind of a simple vision one that helps to provide a concrete example.
And I think, and I mentioned to this to you before, but when we met with you a couple months ago at your location in Toronto, my next door neighbor is an occupational therapist, and she visits many clients in Halton region, and oftentimes she'll be asking me questions about their vision. They're having trouble with their peripheral vision. They're bumping into things at their home. Mm-hmm. So I find it interesting that she's asking me sort of low vision related questions, and she's an occupational therapist. So I think there's a huge opportunity.
Yeah.
Because many OTs are out into the community visiting these folks in their homes and the institutions. So, we typically just see patients in our offices, and when these devices get into the home, it's a different ballgame.
Mm-hmm. And a really important thing to consider is that when somebody has vision loss, it's not necessarily just the vision loss that's impacting them from day to day. It might be related to mental health, having difficulty adjusting to their changing vision, or just an unrelated mental health condition that is impacting them from day to day. They might have other diagnoses. So it's quite common that individuals with vision loss have other comorbid diagnoses, such as someone who's had a stroke or cerebral palsy, multiple sclerosis. These are all conditions that impact physical function, cognitive function, and can cause vision loss. So it's quite common to see some overlap there. And with our aging population, there's definitely an increase in in the number of individuals who have multiple needs. So somebody who has age-related macular degeneration and then also is developing osteoarthritis, they're going to have difficulties for different reasons. So they might have sensation loss, difficulty controlling their hands, and it's not necessarily just about the vision or the person's motivation that you're taking a look at. And where occupational therapy is a good match for that is that we do have knowledge of an individual's function across the spectrum. So we are working with individuals related to physical, mental health, cognitive, sensory, etc. So it's important to be able to take a look at the different aspects of the individual and engage them and help figure out what is going to be the solution or what are the options that are available.
So without getting too much into the details, the low vision space in Canada, in particular Ontario, seems to be on the cusp of some pretty significant change, with certain providers maybe not doing as much, other providers stepping up. Mm-hmm. So do you see a role for OTs in that space, an expanding role?
Yeah, I definitely see a role for occupational therapists, and it's not necessarily changing who the professionals are who are working with these individuals, but adding occupational therapists to the team, especially in situations where you might have a client who has more complex needs and needing to address both, for example, a client who maybe needs to learn some self-management strategies, and they need to learn that in the context of their home. So the OT is working a little bit with addressing the client's vision loss, but also addressing their level of confidence and their independence and their ability to problem solve their own tasks. So there's definitely a need for OT, and it is definitely an area that I can see increased opportunities for collaboration with the other healthcare professionals who are working both in the clinic as well as those who are working in the community.
So on that interdisciplinary piece, just to put on folks' radar, in March of 2017, there's a 2-day conference in Waterloo, I believe, and you're one of the organizers of this conference.
I'm one of the committee members. So Drs. Labreche and Leet are the ones who are hosting the conference, and then they have pulled together an interdisciplinary team to include representatives from different professions.
So just so folks know, I don't think the website's up yet, but March 25th and 26th, 2017. So just if you're interested in this space and delivering low vision, I think that'd be a great conference to attend. So look out for more information on that. And to wrap up, how would someone send a patient to you, Julie? If an optometrist wants to send someone to you for a high-tech consult, how would they go about doing that?
So we do have a referral form, which I will make sure that Jeff has. And we're looking for a medical report that's relatively recent, definitely no longer than a year old, that provides information on the client's vision. So their diagnosis and any other factors. So that might be best corrected visual acuity, field of vision, any additional details. So if they have atropia, is it exotropia, hypertropia, which eye is impacted, etc. Any difficulties with saccades, pursuits, movement of the eye, decreased contrast sensitivity, light sensitivity, etc. So there's a common misconception that ADP has specific cutoffs for visual acuity and field of vision, but in the ADP policy manual, they provide a couple examples, but there's no cutoffs. The main thing is that it's somebody who has low vision, long-term low vision, that can't be corrected medically or surgically or with ordinary glasses or contact lenses, and that this vision loss is impacting their ability to perform their day-to-day visual tasks, and that they are going to require additional devices to help them with reading, writing, and independence at home. Optometrists can definitely send their own reports as well, and if there's any additional information we need, we would just touch base with them to request that additional information.
Okay, great. Okay, well, what we'll try to do is we'll try to link to that referral form within the show notes so our members have quick access to it. So thank you, Julie. Thanks so much for taking time out today for this interview and letting the optometry community know about the important services you provide at your center in Toronto, at OCAD, and also the role of occupational therapy in this space. Thank you very much.